Good morning. Welcome to this class. And for today, this is Dr. Muridi speaking. For today, we have Magdalene Burugu from the Department of Medmicro, a bacteriologist, who will give us an overview of streptococci for this group and for the next group. And when we meet next week again, we'll have another overview of this bacterium before we cover the scheduled lecture. So Magdalene, over to you. Thank you.
Hello.
Hello, Doc.
Are you able to hear?
No.
Okay. Okay, and now? Are you able to?
Yes.
Okay, thank you. Okay, I'll carry on from here. Good morning. And I know we met, but it was online. We are sorry for the other weeks that we have not been able to have practicals, but don't worry, we'll be able to handle everything as we go on. So the rest of the group are with Dr. Mr. Musioki, and let's start. We are going to start on the genus streptococci. This is a genus. I know we told you from the word go, and this has been told by your lectures, that we'll be doing genuses. This is systematic bacteriology. Before at the end we go and start the clinical microbiology, now the diagnostic aspect of microbiology. So for the genus streptococci is a very important genus medically. It is a gram. We have a general characteristic of these. They are pathogens that cause a lot of infections. And so you'll be sent these notes and you'll go through. So what are the learning objectives? So why are we doing the genus streptococci? Generally, we need to know the characteristic, know how to classify the genus so that we'll be able to know the medically important species under this genus. And we'll be able to differentiate, to be able to tell the pathogenesis. And this is what are the virulent factors that the different medically important streptococcus species they use. Then laboratory diagnosis, this will be taken very well in the laboratory. treatment and how to prevent. And so we need also, we know this is an area where we are doing a lot of research, so we need to understand more as you read more journals. So generally, this is what the genus Streptococci. They are another group of gram-positive. And the best thing is that it's the morphology that characterizes them different from Staphylococcus. So the genus Staphylococcus, we are saying staph, meaning grape-like. But the genus Streptococci, we call them strep, meaning in Greek word, chain. So yes, they are cocci, the same as Staphylococci. But now when we examine them after gram staining, we examine them under the microscope. This genus, they show us an arrangement of cocci in chain. And most of the time when we grow these streptococci on agar, most of the time the chain will be able to see smaller, they are shorter, because as we make the smear, we disrupt the chain. But when we want to appreciate this chain, we usually grow from the bronze, and we're able to count even 36. Like in Streptococcus pyogenes, it can have even a longer chain of 36 cocci. So these they are all gram-positive cocci. I've just described. They're usually, some are capsulated, we'll be able to tell. So they use this for their pathogenesis. They are non-motile. They don't form spores. They can either grow facultative. The facultative anaerobe means they can grow either in presence or in absence. And also they are catarrhase. Remember the catarrhase test when we were doing genus Staphylococcus, you were able to see that there were some that were, all genus Staphylococci were catarrhase positive. Genus Streptococci are catarrhase negative. So we need to know, how do we classify them? So we have 3 types of classification that we classify according to hemolysis. We'll see this as we go on, and also you'll appreciate it more when you go to the laboratory. So one of the classification, we use their cell wall. They have a C carbohydrate, what we call, this classification is called Lancefield classification. We use the C carbohydrate antigen that is found on the cell wall. I know by now you know the bacterial cell wall very well. So this classification, it groups them into these 4 groups, and mostly it's to 5 groups, but mostly the groups that we will be able to cover and that help give a lot of course infectious diseases in man will be the group A, Lancefield group A. We have an important medical streptococci under this that will cover Streptococcus pyogenes. Group B will be having Streptococcus agalactiae. There's group C, but mostly we'll also go and cover group D, Enterococcus ficaris. So people used to call it Streptococcus ficaris, but nowadays is Enterococcus ficaris. So this classification, the next classification is on hemolysis on blood agar. So most of these species under this Streptococcus, they are fastidious. They need to be grown in an enriched media for them to grow. So on the basis of hemolysis, we have Streptococcus that grow on hemolysis. They give partial hemolysis, and they will give us like a greenish coloration because their hemolysis is partial. We discussed this very well in the laboratory. A classical example that we'll cover under alpha hemolysis is Streptococcus pneumoniae and viridans streptococci. It's a group we'll be able to see as we go on. Then we have beta hemolysis, of what we call complete hemolysis. These ones, when they grow on the blood agar, they form a complete zone. You can be able to see a very clear zone around the colonies of Streptococcus pyogenes, Lancefield group A, and Streptococcus agalactiae, Lancefield group B. Then we also have another hemolysis that we'll be classifying. We call it gamma hemolysis or no hemolysis. And the important species that we'll be covering is group D, Enterococcus ficaris, which is a normal flora in our GIT. So this is just an example of the hemolysis. So these are the virulence factors. So this is the cell wall. We are able to understand, I know you did this in your introduction class. We were able to see how these bacteria, they do host interaction, what they use for them to be able, that ability to cause a disease. Why these bacteria are able to be virulent. We were able to see, like when you are doing bacteriogenetics transformation, there's one scientist who was called Griffith. He was able to show us that you can, a dead bacteria can transfer the DNA to a live bacteria, and it's able to acquire virulence. So all these are the virulence factors that most of these species under this genus use. We have the capsule. It's the one that we break down. They have the hyaluronan, this one. They help them to evade the immune cells. They'll have for invasion, for them to be able to invade our cells and the tissues. They have streptokinase, hyaluronidase. These are the virulence factors they use. We also have like streptolysine ONS. We'll be able to see all these. Others, they produce toxin. Remember, we were able to see they cause bacteria are also able to produce toxins, and these toxins are the ones that help this bacteria to cause the extraction and now proliferate and be able to cause infection. So these are virulence factors. They are very important in this genus to help them to cause infection. So who is at risk? It's very important, because nowadays we are seeing, we want to understand these infections because we are in an era of trying to infection control. We are not relying much on curing, but we need to understand who is at risk most of the time, because we know these are bacterial infections. They are becoming more serious, because this is an era that we are also experiencing antimicrobial resistance. So we want to understand, there's a lot of research going on, because we want to understand, we want to deal on evidence, we want to have data, clinical data, to know how to go about infection control. So we'll share with you. So what are we'll start with the Streptococcus pyogenes. So what are these infections caused by Streptococcus pyogenes? The infections that are caused, one, there's the superficial diseases. So they attack most of the organs in the body. And we know for bacteria to be able to attack, it means they have virulence factors and they are able to disseminate from one part of the body to the other. So we have the superficial diseases, whereby we have the sore throat, the vaginitis. We know it's very serious. Most of the time, young children, if they are not treated, if they end up having a sore throat and it's not treated, after that, it can end up having even rheumatic heart disease. It can be lead to serious implications. We also see the skin and soft tissue infections. We have impetigo, vaginitis, and postpartum infection. So these are most of the infections that are caused by the species of Streptococcus pyogenes. We also have deep infections. This bacteria has that ability of disseminating to further tissues. Apart from the route of entrance, a portal of entry, they can also be able to cause infection in other tissues. So the list is here. We'll also send these notes to you to be able to see. We have toxin mediated. Remember, we have said that they are able to produce exotoxin that can lead to damage of the tissues and lead to even toxic shock syndrome, which we know sometimes it's fatal. For Streptococcus pyogenes, it also causes immunological mediated. This is one, when we talk about bacteria that are able to enter our body, they evade our host response. Remember, we have a very nice immune response against most of the microorganisms, innate, and also we have adaptive. Maybe we have gotten it passively and also after immunization. But these bacteria, because they have virulence factors, they are able to enter our body and they overcome our immune response. And so what happens whenever we get this infection due to Streptococcus pyogenes, there are times, yes, we are healed, but the immunological complexes that were formed when we were trying to fight this infection, they are deposited. If they're deposited in the heart muscles, we end up having rheumatic fever. If they are deposited also in the glomerular, in our kidney, in the glomerular nephritis, we end up having post-streptococcal glomerulonephritis infection, which are very bad infections. So Streptococcus pyogenes is one of the bacteria that it can lead us to immunologically mediated infections also. So that's why it's of medical importance, and also in the young children and the elderly, we need to do proper laboratory diagnosis and also their treatment. So this is one of the infections that it causes. Because of time, we'll rush through, but we'll still give you these notes for you to go through. And also I know when you go for the practicals, it will be elaborated further. So streptococcal, the throat infection. So we have the symptoms. Ones, and most it affects even the children most of the time, and even us grown-ups. Most of the time, the transmission is through droplets. When we get the droplets, then they are able to go to our upper respiratory tract, and they cause an infection. So they are the mucous membrane. We know we have the immune response in the mucous membrane that we have around our cavity in the mouth, but they are able to overcome it, and they end up causing infection, which is very severe, more so in the small children. They end up having a sore throat, high fever, because we know there's that when we are doing the immunological response, the cytokines that are released, they make us have the high fever when we are trying to fight this infection. There's coughing, and most of the time, otitis media may also occur, the infection of the ears. So this was a paper. You read it, please, to show a prevalence of group A. Remember, we have just mentioned that streptococcal pyogenes, it mostly affects the. It's a very good paper. It will make us understand more. It's very important for us to read. So we also have the complication. It's like I'm even given, I've expounded on this. What are the complications of streptococcal, the throat infection? So most of the time we can end up having this, the autoimmune complications. So you get the sore throat in the small babies or the small children, it's not well treated. And after that, because the immune response will fight, we get those the antibodies. When they come to fight, they are deposited in there. So what happened? They go to the heart valve, they can cause damage. So we end up having rheumatic heart disease. And this is very complicated. It's a very bad thing in small children. It can end up even to heart failure or subacute bacterial endocarditis. This one, it will affect the inflammation of the heart muscles, which is a very bad thing in our small children. Another one, if this immune response are deposited in the acute, in the kidney, I've just expounded on that, we can lead to acute post-streptococcal glomerulonephritis, which is also not very good. So this was just to explain what I've already explained. What happens? I've explained this. It's now well explained here. So that's why we say that I know even when you'll be doing your pediatric rounds, you'd be taught very well how to check whether the kids, they have the otitis media, the infection in the ear, the throat. It's something whenever kids are brought in the hospital, I know you'll be taught on this, how to do clinical, or to see the clinical manifestation, to check on this very well. So what is the laboratory diagnosis? This one will also be explained very well in the laboratory by the other microbiologist, Musioki, will explain very well on this. But most of the time, we usually know that we collect samples We know laboratory diagnosis is very important. We have even seen this right now with the the pandemic that we have been going through, that laboratory diagnosis is it gives us data. It gives us that way that we are able to do prevention measures, So laboratory diagnosis is very important. So we collect specimens for every species. We collect specimen depending with the site of infection. So depending with the infections that this streptococcal pathogen is called, these are the specimens that we collect. So we are able to do direct microscopy, very important. Remember when we were starting, we told you that microbiology, we have not gone full automation. We don't have a machine that we can feed all these specimens, and we are able to tell from the specimen. So it's conventional. The machines that we are having right now that we are using, like in Kenyatta, when you get time, you can pass by Kenyatta laboratory. You can be able to see the new technology that they have adapted. There's the Vitek and there's MAGTOF that it's being used. And also after this, you can be able to check in the internet, in the YouTube, you can be able to see how we are using the MAGTOF and the Vitek to be able to identify these bacteria very fast. So direct microscopy, when we do microscopy of this specimen, apart from blood we don't do microscopy. So blood, we do blood cultures, but microscopy of all these other specimens like CSF, we can be able to see gram-positive cocci. We can be also the parcels. Then culture, this one will be explained very well. All this, let me leave it because of time. So what is the treatment and prevention? Remember, we have said that streptococcal pneumonia, it's an infection that if not well taken care of, what it can lead to more dangerous things. We have seen the rheumatic heart disease, the glomerulonephritis. So it's very important to treat. So that's why we do laboratory diagnosis. And also at the same time, we do antimicrobial susceptibility pattern. And I know with every country, like in our country, we know we have, like, and most of the time, we use what WHO and CDC advocate.
Madam is lost.
Okay, are you hearing me well? Am I audible, class? Am I audible?
Hello, madam.
Yes, you are.
You are audible, but you are not sharing your slides.
Yeah, for now, yeah, I know I had gone, my net had gone off. So let me share again. I'm sorry for that.
Okay, you can continue.
Is it okay now?
Yes, it's okay. Continue.
It's okay. Thank you. Thank you. So another group, streptococci, that would be interested a lot is group B streptococci. The streptococcus agalactiae. Group B, remember it's the, yes, streptococci agalactiae, and Streptococci pyogenes, both are beta hemolytic strep. You'll be able to see this in the laboratory. But we now be able to tell Lancet group A, it's Streptococcus pyogenes. Group B is Streptococci agalactiae. So why are we interested with this? Streptococcus agalactiae, they colonize our gut and also the gastrointestinal tract. They are gram-positive cocci, the same in chains. They are non-spore formers, they are non-motile, and they're usually capsulated. So how do we tell the difference? How can we differentiate? It's the infection they cause. How can we differentiate Streptococcus pneumoniae? Streptococcus pyogenes from Streptococcus agalactiae. That, yes, both of them are beta hemolytic, but we now differentiate them in the Lancet grouping, the C carbohydrate on the cell wall. And apart from that, we also do a biochemical. The gram stain will be the same. There will be gram-positive cocci in chain. They will also be catarase negative, being that they are species under the genus Streptococci, which differentiates them from the genus Staphylococcus. Then there is a biochemical test that you'll be able to be explained in the laboratory. That's why I've left that compound of the component of the laboratory. You'll be able to see the bacitracin test, and it will be able to be expounded more when you're in the laboratory. Don't worry, you'll be able to know how to differentiate. So why are we interested in that? So this is still the pyogenes, the virulence factors. And I know by now you know what the enzymes, the toxins, all these virulence factor. If a pathogen, for a bacteria to qualify to be called a pathogen, it has to, one, to be able to have a portal of entry to our body. Second, it have to learn how, once it enters, how is it able to proliferate and multiply and now be able even to cause a disease. It has to now be able to have the enzymes or have the toxins that will help it now to be able to damage our tissues, and we end up having the signs and the symptoms of that particular infection that is caused by that bacteria. So this one is explained very well. We will not repeat again about the virulence factor that makes the pyogenes become a pathogen. So we are back to Streptococcus agalactiae. Streptococcus agalactiae we have seen is a normal flora, but we are worried about Streptococcus agalactiae more so because of in the neonates. Because it gives, it can manifest into neonatal sepsis and neonatal meningitis in neonates or neonatal pneumonia. So how do they get this infection, the neonates? What happens is that if a pregnant female or a mother, they are carrying Streptococcus agalactiae in their lower GIT, in the vagina as a normal flora, yes, at that particular time. When this baby, when they are giving birth through the, what we call the normal birth, so when they are passing, they pick up the Streptococcus agalactiae, and they can end up having a very bad infection, the sepsis. We know what it means, and meningitis, and the pneumonia, which are very bad infection to the neonates. And so the onset, we have seen that 7 to 90 days, and most of the time is nosocomial. It's because it can also be, it can be also be nosocomial. They can pick it when they are being born. That's why the nurses, maybe when you are giving, you are putting this after the children have been given birth, we usually take very good care. Even we screen the nurses, very important, for those infections that the bacteria that they can give to the neonates. We usually ensure that we do proper infection control where we handle the neonates, like in the nurseries, because they can pick the infections from there. Can end up even being fatal. That's why. So for this, I'll not explain more. It will be explained, but we can be able to tell that the specimens that we can collect for us to be able to do laboratory diagnosis the CSF, mostly when we have neonatal meningitis, blood neonatal sepsis, we can do the blood cultures, the vaginal smears, and also in urine, also even of the pregnant women, we can be able to see whether they are carriers of these streptococcus agalactidae. So microscopy, they will still show us the gram-positive cocci, and this would be explained more in the laboratory because of time. So I've just explained this, how we get, and there's a lot of papers that they're explaining how we are doing a lot of infection control when it comes to streptococcal, all this infection that can affect the neonates. So this is a very nice research paper. Make sure you go through it as you read on other overviews. The best thing with research paper or research articles, they help us now to understand more. Instead of now just being theory that I cram, we are in an era that we don't want only to cram. This is something that we do all the way from pediatrics, obs and gynae, streptococcus would be very important, even when you go to practice, and also when some of you know they'll go and become epidemiologists. They will help us in infection control. Some of you become researchers after this. So we need to understand these streptococcus very well. And we can be able, the research paper and the research articles, these journals, they will help us to be able to understand now very well where we are coming from. Like this paper is a very good paper. It was done in Kenyatta by one of our own people. So please make sure that after this, on your own time, you go through it, please. So we'll go to alpha hemolytic streptococci. So alpha hemolytic streptococci, we have streptococcus pneumoniae that are important, and viridans streptococci. So streptococci pneumonia is one of the organisms that even the elderly, the children, the adults will be able to see it's a causative agent of bronchopneumonia, meningitis, and more other infections. So when we grow streptococcus pneumoniae, it grows very well in the blood agar. Remember, it's a fastidious bacteria. It's hard to grow. So we usually put, whenever we want to isolate it, we use an enriched media, and also we put in 5 to 10% CO2. So all this will be explained very well. So let's explain, understand it on the clinical aspect, and also just to understand what is streptococcus pneumoniae. Streptococcus pneumoniae is an alpha hemolytic strep, and it's also a very nice example that we were able to be shown, and we can do it in the laboratory. We can be able to tell transformation, how bacteria, they acquire a DNA. We can have bacteria that are virulent and virulent. Virulent bacteria are the ones that they are able to cause infection. And we can have a virulent, a bacteria that does, yes, it's a strep pneumonia, but it does not have that ability to cause an infection. So we are able to see a transformation with this species, whereby we can incorporate dead streptococcus pneumonia that were virulent. They had all the ability to cause infection. We culture together with streptococcus pneumoniae that are virulent. They don't have the ability to cause infection. So when they are growing, they will acquire the DNA of infective, the virulence from the ones that are dead. So transformation was shown, the model was shown by Griffith-Watson very well, of how streptococcus pneumoniae, we have they are virulent, they are rough when they grow, and we have the smooth colonies that are virulent because they now have the capsule. So these are the how they cause, they have the pneumoricin, these are the virulence factors. They have the neuraminidase, all these enzymes, they help them to be able to enter our cells, be able to, they also have hemorrhicins they produce. All these virulence factor, they are the ones that help streptococcus pneumoniae to, once it enters our body, it's able to cause infection. So it's the common name that we use is pneumococcus. It has a lot of strains. That's why I'm saying some are virulent. Under the same species, strep pneumonia, we can have a virulent and virulent strains. So they have a normal inhabitant as normal flora in our upper respiratory tract of the human beings. They are gram-positive, but they show us a very good, when we gram-stain streptococcus pneumoniae, they are able to show us diprococci. They are gram-positive, diprococci, and they form short chain, and we're able to see, we say that they form the lanceolate appearance. If we compare the streptococcus pneumoniae gram stain, the way they arrange itself with the other streptococci, them it's diprococci and short chain. They don't from what you have seen in the other image, the capsule, they help them. It's made of polysaccharide, and this capsule we also use it when we want to do latex agglutination. You can be able to do a serological test very fast from CSF to see whether a patient is having streptococcal or meningitis. Instead of waiting to grow it, we use the antibodies against the capsule. So this capsule, it is antiphagocytic. So it helps this streptococcus pneumonia not to be phagocytized by our macrophages, the other cells that are phagocytic, because it helps it to be antiphagocytic. They have the IgA protease. It also helps it in, we have the pneumoricin. This one, it's the one we know in our respiratory tract. We have cereal. I know you had done immunology, or if you have not done, I know that you are doing immunology. We'll be able to see in innate immunity, we have some cereal in our respiratory tract that help us for the microorganism not to be able to gain entry and now cause the infection. But these pneumolycins, they are able to slow the cereal rebeating, and so they are able to cause infection. These pneumoricins are also toxic to pulmonary endothelial cells, and they're also the ones that help in the spread of this organism from the alveoli. It's able now to enter the bloodstream, where it can go and cause meningitis. So these are the virulence factor, that virulence factor that we had seen earlier. So we are able to see the work that it does, why it helps the bacteria and host interaction, so that it's able now to cause the infection. We also have the autolysin. The autolysin, they are the one that break the peptide, that cross-link of the cell wall peptide, that they read to the cell lysis. Remember, for exotoxins to be released, and also some bacteria that produce endotoxins, most of the times the bacteria have to be raised, and they are able now to cause further infection, further damage of the tissues. So we can be able to see the interaction, what we are calling the bacteria and the host interaction, and how an infection is caused. For us to end up with the infections that this bacteria causes, the pneumonia. In the respiratory, we have seen that they have to overcome our cereal, and they're able to be able to foliate and cause infection. We have been able to see they will interact with the complement system. So there'll be antiphagocytic and antiphagocytic cells, and we end up having an infection. So all these bacteria, all bacteria that we call them are pathogen. All these bacteria that are able to cause infection in a healthy individual. Remember, we also have opportunistic pathogen. I know it was explained very well in your introductory class. So pathogen, this bacteria, for it to be a pathogen, to infect a healthy person, it has to overcome the immunity for it, the immune response to be able to cause an infection. So the virulence factors, they help this streptococcus pneumonia to fight our immune response and now cause the infections that we have seen. So this is just a very nice instructive. It have explained all what I had expounded on, how we end up with otitis media, how we end up with bacteremia when they circulate in the blood, how it end up after bacteremia, that's when it will end up to meningitis. I've explained all this, and we get it from the aerosols. They enter our system, and also we have been able to see when you are healthy, they have to overcome all that in the previous for them to cause the infection that they cause. So if you understand your immunology very well, you'll be able to understand how these bacteria, even when you when you did your virology and when you're doing your parasitology, you'll be able to understand that for this bacteria, viruses, or fungal, or the parasite to cause infection, they have to overcome our immune response. It's only that opportunistic pathogens, because this person it's already immunocompromised, then they cause infection very fast. That's why we see most like HIV patient, those in these bacteria infections are worse there, or small children where the immunity is not well developed. So this is the laboratory diagnosis. I won't talk much. This one will be expounded more in the laboratory. So even this, the queram will be a test because of the capsule. We can be able to do this even in the laboratory. It will be explained very well in the lab. All this, I won't rely much on it. It will be done in the laboratory. So treatment and prevention. So this is one of the infections that we are doing in prevention. That's why in when we are doing the immunization of our small children, I know you know the immunization package that we have in under Ministry of Health. Streptococcal pneumonia is one of the vaccines that was added that is given to small children. So we try to prevent because they are vulnerable to bronchopneumonia, and pneumonia, it leads to death in small children. So that's why we use prevention. Right now we are dealing with prevention a lot. So vaccines are there, and these vaccines are prepared on the streptococcal, also the strains that are virulent. So because remember streptococcal pneumonia, we have said that there are some, they are virulent, they don't have the ability to cause infection. So in the treatment, we have penicillin. It's a very nice drug, and ampicillin. Though right now we are seeing a lot of resistance. Remember, we are in an era where we are experiencing AMR, antimicrobial resistance. And so that's why there's a lot of research in AMR. But now after this, if this are because of resistance, we give ceftriaxone. It's very good, like more so in the inpatients. As IV, we have cefotaxime, the carbapenems, antibiotics. I know you did your antimicrobial, so you understand these antibiotics. And as you go on, you'll understand them better. So these are the antibiotics of choice for treating pneumococcal infections. So, and we are doing a lot of vaccine. And what is this vaccine? This vaccine, remember, because we know not all streptococcal that are caused in some will be a virulent, but they had to come up with a vaccine that's the one that they are giving it nowadays to the small children, that it has to cover most of the pneumococcal strains that are able to cause infection. So we are using the capsular polysaccharide because we are able. I told you the antibodies, even when you're doing the querang test, to be explained very well, you'll be able to understand why. So we have these are the types of saccharide that they have been separately activated and conjugated to a protein carrier. And this is the vaccine that is being used even in our country for immunization against streptococcal pneumonia. So the rest of the group that we are going to do is viridans streptococci. So earlier we used to do streptococcal viridans only. But nowadays, we now came to realize after a lot of research and that streptococcal viridans is not a single species. It's a group. It has a lot. You'll be able to see as we go on some streptococci that fall under viridans streptococci, and we'll be able to discuss the infection. This group of viridans streptococci, they are also alpha hemolytic. In the lab, you'll be explained on how we differentiate between streptococcal pneumoniae, which is alpha hemolytic, and the group of viridans streptococci, because both of them, they are alpha hemolytic. So we cannot tell the difference very much when we grow them on the agar, the blood agar or the chocolate blood agar. It's only that we have some strains of streptococcus pneumoniae. When we grow them on the blood agar, you'll be shown this in the lab. They show us a very distinct elevation whereby the colonies, they grow. They form, yes, the alpha hemolysis, but those strep pneumonia, the strain, it's able to show us Draughtsman elevation. So very nice, you can be able to see it in the laboratory with our naked eyes when we are doing macroscopic or what we call colonial morphological characteristic. But initially, the others that don't show Draughtsman elevation, strep pneumoniae, you cannot differentiate them when you grow them on the chocolate blood agar and blood agar with simply the colonial morphology, because they will appear as colonies that are showing alpha hemolysis. You'll be explained better. So viridis, it means green. They are also commensals in our throat, but why are we interested? Because sometimes they can cause opportunistic infections. So I've just explained that they are alpha hemolytic on blood agar, and this is the group. These are some of the species that fall under viridans group of streptococci. We have Streptococcus mitis, Streptococcus mutans, salivarius, and sanguis. So most of the time, they bring a problem. They'll just be there as normal flora. But when we have now, maybe for example, a tooth is extracted. So once a tooth is extracted, we know now there's the way that the bacteria, which was a normal flora, can now gain access. And also in cases of prosthetic heart valves, when we have some implants in our heart valves, that's when we can be able now to see this group of viridans streptococci becoming now a problem. Initially, the group of viridans streptococci, they are normal flora. We have their throat commensals. We stay, everybody, most of the people, if we can swab ourselves in the laboratory and we grow, most of us will grow. We'll see the following morning, we remove the plates. We'll see alpha hemolysis on blood agar or chocolate blood agar. We stain, we'll be able to see and identify and see viridan. Most of us, almost in the population, we are carriers of viridan, group of viridan streptococci, but not as pathogens, but as throat commensals. But they will cause an infection. There must be a predisposing factor for them to cause an infection. Also, we see there are others. So we have seen the group Streptococcus sanguis is more when it comes to this infection, which can lead also to bacteremia and all that. Then Dentocari's commonest species is Streptococcus mutans. All this, we have said that they are under the group of viridan streptococci. So they have that ability to synthesize dextrans from glucose, which allows them to adhere. You know, for this bacteria to cause infection, they have to show adherence. Enter, they're able to enter, so they overcome our innate immunity, or they take advantage of the predisposing factor that we are having. Like here we have said about tooth extraction, and now they are able now to to take advantage of that, and they cause the infections that we have. Yes, they are normal commensals, but they can lead to those infections. So the clinical manifestations from the viridan group of streptococci is the dental caries. All these are the clinical manifestation. That's why we are worried about viridan streptococci. Yes, they are normal flora, but they can end up, when there's the predisposing factors are there, you can end up getting all this infection. Like we are also seeing subacute bacterial endocarditis, brain abscesses, which they are very bad infection, and abdominal abscesses. So laboratory diagnosis, I will not explain about it, to be explained in the laboratory because of also our time. I'm seeing most of you now want to leave for the practicals. So treatment, we have to have a prophylaxis to patient at risk during dental surgery. So there's a lot of care so that these microorganisms don't gain entry. So these are the drugs of choice that we use, though we also have seen some, for this there's not a lot of antimicrobial resistance. So these drugs, we use them for treatment. So I don't know whether we have time to cover the enterococcus. Are we having time, or time is gone? Class rep, we continue. Are you still there?
Yes, you can continue, madam.
Okay, thank you. So the other group that we are supposed to cover is Enterococcus faecalis, the group Enterococcus, and an important is the group D streptococci, is Enterococcus faecalis and Enterococcus faecium. So Enterococcus faecalis, they are normal flora in our GIT and also in our lower genital tract. So I know you did a topic on normal flora, which was very important for you to understand now more, to expound more on how bacteria cause infection. And that's why please make sure you understand from the way you started, all the way from the bacterial cell. While you did a topic on sterilization, staining, the microscopy, how to identify these bacteria as you go on, and that bacteria-host interaction, how these bacteria are able to cause infection. Now, as you go on to deeper now bacteria, you'll now be able to understand why are we doing these genuses, why are we having this species of a bacteria causing infection at a particular site of the body, and some, they will only cause infection at the route of entry once they enter. Others, they are able to enter. We have the different portal of entry of microorganisms or these pathogens, the way they overcome the immune response of a healthy individual. We also have pathogens that we call opportunistic. Please make sure that you understand this before we go on. Just make sure that you understand on this. What you did, the topic on normal flora, you'll now be able to appreciate more as we go deeper to bacteriology. The best thing, please don't keep your notes. Then when you hear there is a cut or an examination, remember we are not here because of a cut or because of an exam. Then we are in a tropical country. Microorganisms are still a burden to us. Yes, we are having lifestyle diseases right now. We have cancer, we have the diabetic being a major problem. We are seeing microorganisms because even in the cancers, they are induced by microorganisms, some of them. So please understand microbiology very well because this is something, even after this, if you're going to be a researcher, an epidemiologist or public, you'll be able to go to the public now to help us infection control on policy level. Also, when you're doing the treatment, the diagnosis of this patient, it will help a lot. So let's do our bacteriology from introduction, understand how bacteria enter the portal of entry and how they cause infection, and where are they found as normal flora. Because we will be able to see as you go on, some bacteria that are normal flora in our own body. When they move from the site in the body where they are normal flora, they now cause infection. For example, you'll be able to see this enterococcus. Yes, they are normal flora in the GIT and in the lower genital tract. But when they move from where they are normal flora, or when a patient comes into the hospital, maybe in a burns unit, or they have wounds, this enterococcus faecalis is able to enter and cause an infection. So we can end up having this enterococcus, despite them being normal flora, we can end up having nosocomial infection from them or opportunistic pathogen. More so from those patients, we know in our population right now, we are having a lot of people who are immunocompromised. So the infection that this group, this streptococcus, and it shows no hemolysis. It has a gamma hemolysis. We'll be able to be shown this in the laboratory. These are the infections that they cause: urinary tract infections, wound infections, endocarditis, and also we are seeing that enterococcus faecalis, years earlier it was not a problem with treating the normal antibiotics, but we are having a resistance to cephalosporins and also vancomycin. So we are worried now because of enterococcus, more so with the nosocomial infection and as an opportunistic pathogen. So what are these points to remember? So one thing I want to, all this will be expounded more in the lab, is that enterococcus faecalis is something, when if you go to a hospital like Kenyatta, in their microbiology lab, you will not fail to see they isolated and identify if it's a common pathogen among from staphylococcus. When we'll be doing a genus Enterobacteria, so you'll be able to see these are pathogens and opportunistic pathogen that we isolate a lot in a microbiology laboratory. So the things that we should not forget at all is the general characteristic, the hemolytic patterns. We have talked about beta hemolytic strep, which you appreciate more when once you go to the laboratory. The last grouping, then the infection, and we have been able to see, and also we do more in the papers that have been given by Dr. Miriam. They will expound more on that. Microscopy test, I didn't do much because Musioki is going to do that in the laboratory very well. And also make sure that you do check on the papers. Most of the papers, we are having an emergence of resistant strains, more so causing the nosocomial infections, and how vaccines are very important, more so when we are coming to streptococcal pneumonia. We are able to give vaccines to our small children, the population. So this is just a very nice that is showing us why are we having challenges. Like in vaccine, in streptococcal pneumonia, remember we have seen that it has many strains. So we prepare a vaccine, maybe we have packed, this vaccine is against like 4 strains. But now the small children, now there's another strain and it causes an infection. So because they were not immunized against that particular strain, they'll still go down with pneumonia. So that's why we are having a challenge right now. You are the young generation who are going now to do a lot of research and give us how to solve this. You are the problem solvers. That's why you are now here in medical school, or what we call the Faculty of Health Sciences. We need to know the risks. Like when we don't treat the small children, that's why it's very important to be able to treat before they go and induce autoimmune infections like rheumatic heart disease and the glomerulonephritis, very important. And also, how do we take care of these pregnant women? Can we treat them? Can we be able to incorporate screening of streptococcus agalactiae group B so that we do away with neonatal or sepsis, neonatal meningitis? So these are the things that they are under research, and also we are saying will be part of the solution for this. So these are the formulations we'll be able to see as you go on, and kindly make sure that you read the papers that have been highlighted here. This one will be expounded very well in the laboratory. You'll see this when you go to the laboratory. Unless there's anyone with a question, I beg to stop it there. I know you'll be expounded more in the laboratory. Anyone with a question, please? I'm sorry I've moved fast because of time, because we want you to get time to go to the laboratory. Anyone with a question? Question, or maybe you want to add something, class, or we leave the meeting? Anyone?
Hello, madam.
Yes.
Okay, if I may ask, I wanted to know if the practical is going to be one which you are going to do it, or it's going to be projected.
Okay, I don't know how he has planned, because what we are doing, no, we have not been bought all the things for you. Though the Vice Chancellor came on to the college, we don't call it a college anymore, to faculty of health sciences, and we were able to be promised they will buy everything. For today, we have cultured few people. The plates are there, the gram stains are there, the biochemical tests are there. Remember also, I have not explained more on the laboratory diagnosis, and Musioki is going to explain it. Please make sure you go for the practicals, please.
Yeah.
Thank you.
Okay. Thank you, madam.
Okay, you're welcome. And thanks for having me, and we'll continue more. So Musioki will take care of you. He's a very good microbiologist. Thank you.